loneliness and isolation, social isolation, are topics that are of huge interest globally. And I think they have a particular relevance for health and social care research, as will become apparent as we move through the session. So this afternoon, I intend to talk to you about several aspects of loneliness and isolation research. So what they are and what they're not. We're going to look at things like time perspective and why that's important, the different types of loneliness, and why that is important when we think about measurement. We're going to look at who's at risk. We'll look at prevalence, and then we'll end looking at some of the main issues in loneliness research and some of the barriers. So to start, let me see if I can get this to move. Right, hang on. I don't think that's moving. So this is a quote here from Olivia Lang, who wrote about loneliness. And loneliness is a universal human emotion. It's a really unpleasant one. It's one that we're not very comfortable talking about when it affects us. But it is something that most of us will experience at some point in our lives. I think none of us are immune from loneliness. And when we feel lonely, as I said, it's a difficult one to admit to because of the stigma attached. Sorry, did somebody say something? No. Okay. It's been argued that loneliness is an adaptive mechanism in a similar way to the way we experience physical pain that reminds us or alerts us that there's something wrong with our bodies. Loneliness alerts us that we need social connection. As humans, we're a social species, and we need our social network and those connections to thrive and be well. So what are loneliness and isolation? Loneliness is experienced when it results from a process where, as an individual, you'll weigh up the social connections you have already and your existing personal relationships with family, friends, and neighbours, and you'll measure those against your own wishes and expectations about those relationships. And when you perceive there to be a bit of a disconnect between what you'd like to have and what you've actually got, either in the quality or the quantity of the relationships that you already have, then you'll start to feel lonely. So it's a very subjective construct. And what this means is that you might be a person with a very small social network, but never experience loneliness because that network meets all of your needs. Or you could be a person with a large network of family and friends around you, but feel really lonely because there's something lacking in either the quality or the quantity. As it's subjective, it also means that the point at which you'll experience loneliness will be very different from somebody else, even if they're in similar circumstances to yourself or have similar experiences. And because it's subjective, it's going to be experienced differently by different people. And this can be problematic when we want to identify someone who's at risk, and we'll look at the measures and who's at risk later on. And what I mean by sort of the experience differently, the loneliness of somebody who's been recently bereaved and lost a life partner might be experienced very differently to someone who's moved to a new city and doesn't know anyone and are feeling lonely because they have no connections in that area. Social isolation, on the other hand, is an objective construct, and it refers to a lack of or paucity of social contacts with family, friends, neighbours, and the wider community. Since it's objective, we measure it by looking at the number of contacts a person has with others, and when it falls below a certain number, we deem them to be isolated. And unlike loneliness, social isolation runs on a continuum. So we have social participation at one end and social isolation at the other. And I think so one of the key messages really here that I would like you to take away is that loneliness and isolation are related but distinct constructs. And we often see these conflated, and it's a real bugbear when you're looking at papers around loneliness and you see actually what people are measuring is social isolation and not loneliness. And very often we see proxies being used for loneliness, things such as living alone or social support. And so I'll touch on that a little bit later. And what this means, though, because they're distinct constructs, you can be lonely without being isolated. You can be isolated without being lonely, or of course you can be both. People who are socially isolated run a greater risk of becoming lonely as they get older. So let's move on. So what loneliness isn't, and some of these are some of the constructs that we see them getting conflated with, are things like aloneness, solitude, and social exclusion. And they are different. Aloneness, we might choose to be alone. We might crave solitude. We never choose to be lonely. And I think that's the important distinction. And with social exclusion, if social exclusion can lead to loneliness, but they're not the same things. So loneliness itself is a complex multifactorial construct, and it falls into three broad types. So we have existential loneliness, which refers to a sort of broader separation related to the nature of our existence and a lack of meaning in life. And there was a review done in 2019 by a Swedish academic called Bonsfleur, who tried to identify the different aspects that made up existential loneliness. And these included not connecting with the others or the world outside, feelings of alienation, feelings of emptiness, and feeling abandoned. Well, Moustakis, who is one of the key proponents of existential loneliness, argues that it's inherent in all humans. We all have that capacity. And indeed, existentialist scholars argue that this sort of loneliness is a chance to reflect, to ask why, and to look for meaning in those moments when we might feel despair. And indeed, there's like a whole philosophical discussion about the differences between existential loneliness and so-called psychological loneliness. Now, the other two types of loneliness that we'll come across most frequently are emotional loneliness. And this originates from the absence of an intimate figure, or such as a partner or close emotional attachment. And on the slide, I've just given an example from somebody I interviewed who is how she defined emotional loneliness. And then below, we've got social loneliness, which originates from that absence of a broader group of contacts or engaging in a social network. So again, it's a quote from a participant who said, "There are days when I don't see anybody at all." And these, particularly emotional and social loneliness, will be important again when we come to look at the measures. So another aspect of loneliness research that we really need to consider are time perspective. Loneliness is not a static state. It can fluctuate in terms of intensity and in the frequency of those negative feelings. So some people report loneliness being a seasonal thing. And we've all probably seen the adverts at Christmas with the lonely older person at Christmas. And actually, just as many people experience loneliness in the summertime because everyone's more visible because we're out and about in groups of friends and family, and that can make somebody feel extremely lonely. There's also a spatial element to it. And this is something that participants that I've interviewed have spoken about. I've had an example with one woman who felt extremely lonely in just one room in her house. And it was a room she avoided because it was a room she associated with her husband when he was alive. We also know that loneliness can be amplified around sort of key anniversaries and holidays. So the time perspective is really important. And loneliness can fall into situational, transient and chronic forms. And in terms of our health and health impacts, obviously chronic loneliness, as its name suggests, is long-term. For some people, it's a lifelong experience. And that can have a really negative effect on our physical and mental well-being as we experience it. Transient loneliness, I would argue, is most of us would probably experience that. You might look at no friends are out and about on the Saturday night and you're stuck at home for whatever reason and feel that experience of loneliness. While situational loneliness, that occurs during certain periods, so like a bereavement, the onset of an illness, becoming a parent for the first time can trigger loneliness. Situational loneliness can become chronic loneliness if we don't address it in time. So who's lonely? As I said before, none of us are immune, but like most things in life, loneliness and social isolation are not created equal. And groups that are particularly vulnerable to loneliness are people with disabilities or limiting chronic conditions, where over 50% will report being often or always lonely. Young people, aged 16 to 24, I mean, Action for Children found that 43% of the young people who were using their services reported being lonely. Care leavers, 1 in 5 will report loneliness. It's also an issue among informal carers, and we've got some data from a recent study called the Ideal Study, which found that 44% of informal carers were experiencing moderate loneliness, while 18% were reporting being severely lonely. We also see high rates of loneliness in ethnic minority communities. Research in the UK found that prevalence of loneliness was particularly high and among older people from an ethnic minority community. But the same is also true for migrants, refugees, and asylum seekers. And that's certainly probably not helped by the hostile environment that we experience in the UK at the moment towards those groups. Prevalence is also high in the LGBT community, with data collected prior to COVID suggesting around 21% of the community were often lonely or experiencing loneliness every day. Obviously, older adults are at risk, but older adults moving into care are at elevated risk. And there's a socioeconomic gradient to loneliness as well. So we know, for example, that in very deprived areas, some research done in Glasgow by an academic called Aid Kearns found that situational loneliness existed without being triggered by a crisis or a transition or some sort of disruption. And it seemed to be related to the possibility or the lack of possibility of contact with others, particularly family and neighbours. And in the case of deprived areas, these possibilities of contact can be affected by things such as the structures of buildings and streets, the implicit messages that are being sent out by the built environment. So if we see broken street lights and graffiti and lots of rubbish, it can tell us that this space is not safe and you can't trust people living in these areas. And the provision of local amenities. So in deprived areas, there are fewer services. Things like territorial boundaries and high residential turnover can all make people living in those areas feel extremely lonely. And in the Glasgow study, it was 2 in 5 of the sample reported feeling lonely, while 1 in 6 reported being frequent loneliness. And as I said, we can all be lonely at any time in our past, our present, or our future, and it can affect any one of us at any time. There's less data on social isolation, and you might wonder why I haven't touched on that. You very rarely see data on social isolation collected outside of academic studies, and it's certainly not routinely collected at a national level, unlike the data on loneliness, which both UK and Welsh Government collect. And you mostly see it around the impact of COVID-19 when we were all locked down and maybe feeling isolated. So who's at risk? Well, as I said, it affects all age groups, but prevalence rates have been found to be higher in young people and older adults. So you see this U-shaped distribution. And different factors contribute to loneliness for these particular age cohorts. So for younger people, severity of loneliness might be linked to a developmental or transitional change. So starting university, leaving home, starting employment. Whereas for older adults, it can be linked to the loss of a partner, family members, moving into care, the onset of chronic illness, and so forth. So we can look at some of the risk factors for young people, and then we'll move on to look at some of them for older people. So I've tried to group these into sort of 4 broad categories. So we've got socio-demographic, health, life events, and as a function of location. In terms of health factors, long-term disability, illness or long-term illness or disability in a young person can really impact their formation of a social network. And there was some research done in Sweden that looked at adult survivors of childhood cancer, and they found that the adults that had survived cancer in childhood were less likely to be married or have a partner than their peers or their siblings. And we know that marital status is one of the risk factors for experiencing loneliness. So not being married, being divorced or widowed will increase your risk. So for young people with those experiences of chronic illness really early in the life course can have quite an impact as they move through their own life course trajectory. And of course, and I've seen this in people I've interviewed who've spoken about it, but also in family members who've had chronic illnesses. If you're in and out of hospital all the time, your relationships get fractured. Children can be quite cruel at times. And so the barriers go up, and the person with the illness or the condition find it more difficult to make those connections. Financial resources and socio-demographic factors, that's self-explanatory. If you can't afford to participate in activities like your friends, or your house is in a state of disrepair, then you'll be less likely to invite people home or be able to engage in those activities. And in things like high residential turnover and lack of amenities we've touched on previously. So for older adults, again, I've sort of tried to group them in a similar way. So the older you get, the research suggests the more likely you are to become lonely, but that's probably the result of cumulative factors. So if you end up with a cognitive impairment or some sort of functional disability, or you end up being a carer, these things have a cumulative effect on your ability to engage and participate. As I said, admittance to a care home. Retirement migration is a really interesting one, because I think lots of people think, oh, when I retire, I'm going to move to the coast or the country. Don't. Lots of people that I've interviewed had done that and then found themselves isolated from their wider communities from where they were living previously, and have experienced loneliness and social isolation. So I think if you retire migrant, it's important to find a way of plugging yourself into those networks really quickly. Housing tenure, you're more likely to be lonely if you were in council or private rented. And things like educational level and access to a car, again, sometimes we use those as sort of proxy measures. So there are a number of risk factors, just to sort of show the complexity really of loneliness and social isolation in both age groups. And this, I've put this diagram up, and it's probably not that easy for you to see, but it's trying to illustrate the impact the social network can have on health. And it's a conceptual model developed by Berkman and colleagues. And they suggest that there are several mediating pathways through which our social relationships can actually impact our health. And these include through the primary pathways of things like social support, social influence, social engagement, attachment, and access to material goods and resources, which in turn influence the proximate pathways to health. So things like physiological stress, psychological states and traits, health damaging behaviour, and things like exposure to infectious diseases. And then they take it a step further and suggest that there's a cascading causal process that begins at the macro and then filters down through those various pathways to impact on health. And I think the reason I've put this here is very often when we think about loneliness interventions, we address them downstream once people have become lonely and isolated. And I'm a huge advocate for prevention as much as possible, and moving upstream and trying to prevent people becoming in that state in the first place, or prevent them becoming chronically lonely. So, and like I said, it also speaks to the fact that it's not just down to the individual, it's the wider environment that they live in, their communities, things like welfare regimes and so on. And I've put a quote here. This is from a really well-known piece of research by an academic in the States called Juliana Holt-Lundstad. And this sort of research has demonstrated that loneliness and social isolation in their chronic forms have a really significant negative impact on our health and well-being. And you've probably heard the statistic where it's comparable. The magnitude of the effect is equivalent to smoking 15 cigarettes a day. What we do know with loneliness is it's associated with an increase in morbidity. It increases the likelihood of mortality by 26%. And I said there's a similar effect on, the impact is similar to the well-known risk factors such as obesity, physical inactivity, and smoking. But loneliness has also been associated with poor sleep, increased cardiovascular reactivity, an increased risk of developing coronary heart disease and stroke. We know recovery is slower in people who are lonely or isolated. In relation to our mental health, it puts you at greater risk of cognitive decline and dementia. And if you already have a cognitive impairment, it increases the risk of loneliness. So you can see that negative spiral. It can touch on that a little bit later. Well, because we have a question about that later on. We also see loneliness associated, unsurprisingly, with things like social anxiety and depression. Low social interaction and loneliness are predictive of suicide in older adults, and I strongly suspect that's probably the same for young men. We see an 8% increase in hospitalizations among people who are lonely and isolated, and a 57% increase in emergency department use. And there's also some evidence to suggest that people who are lonely or isolated visit their GP more frequently. If you are lonely and isolated as an older adult, you're more likely to go into care, formal care earlier, and there are also risk factors for the progression of frailty. So it does have a massive effect on our health, which is why governments globally are so concerned about it. So this is a global map of prevalence taken from an article in the British Medical Journal. And I'll touch on that in a minute. So a global survey found that 33% of the world's population are lonely. And obviously there are variations within countries. In Europe, 13% of EU citizens were lonely most of the time. Well, rates between countries within the EU, loneliness was most prevalent in Ireland, with over 20% of respondents reporting feeling lonely. Luxembourg, Bulgaria, and Greece sort of follow that, so it was around 20%. The lowest levels were observed in the Netherlands, the Czech Republic, Croatia, and Austria. Now, in the UK, 2023 data suggested 49% of the population were reporting loneliness, and 3.8 million people were chronically lonely, with women more likely to be chronically lonely than men, and individuals from non-white populations more likely to be lonely than their peers, their white peers. In Wales, around 15% of the population is lonely, and it's an issue that's not really going to go away. Several countries, including the UK, have seen an increase in prevalence since the end of the pandemic. So in the UK, 500,000 more people were reporting chronic loneliness than prior to the pandemic. And similarly, in Europe, they've seen an increase from 12 to 25% since 2016. As I said, there's limited data on social isolation outside of academic studies. And it's something that I have raised in meetings with the Loneliness and Isolation Strategy Board. What data we do have in Wales comes from the Cognitive Function and Ageing Study Wales, which found that 18% of older adults aged 65 and over were isolated, and 11% were lonely and isolated. And as I said, this image is taken from a nice systematic review and meta-analysis published in the BMJ recently, which looked at loneliness across 113 countries, drawing on data from adolescents, young adults, middle-aged adults, and older adults. So you can see it's a global spread of loneliness. Some refer to it as an epidemic, but that's up for debate. So how do we measure it? If we're interested in loneliness, how do we measure it? There are several approaches. used to distinguish between those who are lonely and isolated and those who are not. So I can't get this slide to move on. There we go. So if we look at measuring loneliness first, a common approach is just to use, in large population scale studies, is to just use that direct question, are you lonely? And then it's a self-rating, like a Likert scale, never, sometimes, often. One of the disadvantages of using these single item measures, because they mention loneliness, is you tend to get underreporting because of the stigma attached to admitting that you're lonely. So in contrast to that, there have been a number of unidimensional scales developed, and two of the most popular are the University of California, Los Angeles, which is on the screen, and the Dion-Gehfeld scale. So the UCLA scale is used by the ONS in England. It was developed primarily with college students in the US, and it assesses the subjective experience of loneliness by asking questions like, how often do you feel that no one knows you really well? How often do you feel you can find companionship? And again, it's a Likert scale, so never, really, sometimes, always. Unlike the single item questions, the UCLA makes the distinction between that social and emotional loneliness that I referenced earlier. But it's critiqued sometimes because there's an underlying assumption that it assumes that loneliness is experienced in the same way by everyone, regardless of the cause. And this measure, it comes in a 20-item scale, a 4-item, or a 3-item. The other scale that is commonly used, and one that I use most frequently, and it's the one that Welsh Government used to monitor loneliness in Wales, is the Dion-Gehfeld loneliness scale. Again, it distinguishes between those emotional and social loneliness by asking questions like, I experience a general sense of emptiness and I miss having people around me, to measure emotional loneliness. And there are many people I can trust completely, or people I feel close to measure social loneliness. And again, the response of none of the time, rarely, some of the time, often. What's unique about this, and it's why I use it, this is a scale that I particularly use, is you can get a total score of the emotional and social loneliness, or you can split it. So you get a score for emotional loneliness and a score for social loneliness. And by considering these two dimensions, I think we can shed light on whether loneliness is taking the form of a desire for a larger social circle, or a sense of a lack of a meaningful relationship in the emotional loneliness element. And I think this is important if we're thinking about interventions, because there's no point developing a group activity for somebody who's emotionally lonely, and vice versa. There's also an existential loneliness scale. This is sort of more recent. There's less research on this aspect of loneliness compared to the others, but I just put it on the slide so you could see that it is measured. It's usually measured, used at the end of life, and in sort of palliative care. So likewise, there's various measures for measuring social isolation, and they're not without their problems. Because social isolation has been conceptualized as an objective construct, this has been contested by some loneliness and isolation scholars. So, for example, Christina Victor has argued that social isolation is purely a quantitative approach, presumes that all interactions have the same value. While Hormel and colleagues have argued that there are two aspects of social isolation, and it should be the social disconnectedness characterized by a lack of contact with others, and perceived isolation, which is the subjective experience of reduced social resources. But because there's a lack of clear conceptualization around social isolation, there's been some questions about the psychometric properties of the measures. So again, the two most common are the Berkman sign, and it measures structural features. So you can see on the screen, it talks about relatives and close friends, church membership, and formal group associations. And it's measured about how many relatives do you have that you feel at ease with, and then you score them accordingly. And then the one that, again, I've used quite frequently is the Love and Social Network scale, which again focuses on those sort of functional characteristics of social connectedness. But they sort of, on this one, it measures them in equal amounts in different relationships. So the homogeneity and reliability of the scale is generally considered satisfactory. A more recent scale is this one by Nicholson, and again it's looking at 3 items, whereas the other scales were developed many years ago. This one being recent, it actually looks at connection through email, phone and internet and video chat, and tries to calculate how often you see your friends, families and neighbours face to face or virtually. There are other approaches as well. So there's one which uses a set of interconnecting circles, which is quite useful if you are trying to collect data with individuals with a cognitive impairment or perhaps a learning disability. And we've used it in the past where we've used dolls, and the person themselves places themselves in the middle of the circle. And then the people who are the closest to them are in the next circle. And as they get more proximate relationships, they move out to the outer edges. And that's sort of quite useful to see who they, because they name individuals, you can see how many people they've got who are really meaningful to them. So the main issues in the study of loneliness and social isolation are, oh, crikey, sorry, let's go back. I just stopped screen. I've stopped. I don't know what I've just done to my screen. Sorry. You don't need the screen for this one anyway. The main issues in sort of studying loneliness and social isolation, and I've touched on these previously about these conceptual inconsistencies. And this was flagged in a review, a 2018 review of reviews of loneliness studies. And one of their findings was this lack of conceptual clarity around loneliness in published and in unpublished literature. And as I mentioned earlier, they're used interchangeably with other terms such as social exclusion, aloneness. There are also issues around the concept of social isolation, as I said, because its definition and measurements are not really well established. And it's argued that there's been a lack of theoretical embedding and elaboration of that concept. It's also really seen as a continuum. You're either isolated or not. And I think one of the problems with that is at what point is somebody connected and what point is somebody isolated? And although there's cut points, they're really arbitrary. And I think we probably need more work on that. There are also inconsistencies in the measurements. You've seen the scales very briefly, but they're measuring similar things, but they're not exactly the same. So if it makes it hard to make comparisons across studies. And I said we've touched on it earlier. So, you know, synonyms for loneliness are living alone, isolation. And this is more than just semantics. These are really important when we're developing research or when we're trying to interpret the data, because these conceptual inconsistencies have a really profound effect and influence on the generation and interpretation of that evidence, particularly when we're deciding what interventions work for whom and in what context. So getting this correct is vitally important, and I would argue more so as we potentially see things like AI and machine learning being developed to address loneliness, because if we don't get it right now, particularly in those studies, we risk doing more harm than good. An additional issue is that loneliness and isolation in published papers are not always reported as a primary outcome. They're usually reported alongside other things such as health, anxiety, depression. And I think conceptually, interventions should identify their goals in terms of what they're focusing on, whether it's reduction, prevention, or both. I would argue also there's a little evidence of interventions that target those who are lonely or at risk, despite the recognition that targeted interventions may be more beneficial. And I think this is particularly important if people are on a degenerating pathway. And I think what I mean by this, some people know how to plug themselves back in. So they might have experienced a bereavement or whatever, but because they've had social groups in the past, they know how to reconnect themselves. Whereas the people we're not capturing, the information from those who don't come to the attention of services. And I think sometimes, the best will in the world, we design interventions that we think will work for somebody who's lonely. And I think we should be co-designing them with them rather than for them. I would also argue there's a need for a more nuanced analysis. So although we look at loneliness and isolation separately, we could combine the measures. So I've in the past have combined the de Jong-Geerveld with the Lubbock social network scale to give 4 categories of loneliness and isolation, which is not lonely, not isolated, isolated, not lonely, lonely, not isolated, and both, lonely and isolated. And I think this nuanced analysis gives us an insight into the risk factors that are predicting inclusion in each of those categories, which would then give us a clue as to what interventions would work for people in each of those categories. So I think it would help us refine interventions and target them much better if we had a better understanding of which group and which classification they sat within. And I think the other issue we have at the moment is that we're very focused on the individual. And there's a lot more work needs to be done on sort of the macro and meso influences and factors that can ameliorate or maintain loneliness. Things such as community place, built environment, policy, welfare, they're all important if we're going to address some of those place-based differences, because they're not the result of an individual experience in an individual circumstances. There's wider things at play here. And in terms of the barriers, well, there are a number of barriers. The biggest one, I think, when we're trying to recruit and work with people who are lonely or isolated is the stigma. We try to overcome this. I think the more people talk about their own experiences of loneliness and isolation, the more we chip away at that stigma in the same way that we've done with mental health. As I said, there's also a tendency to see people who know how to reconnect. And I think we need to find ways of engaging people who they're not necessarily hidden, but because they don't come to the attention of services, there will be people in the community who know who these individuals are who are chronically lonely and isolated. So people like the fire service, myself and Claire have spoken to the fire service in the past about this issue, and they can identify people who are particularly vulnerable. But there are also others working in the community who can help flag people they suspect. And we'll all know somebody in our community, somebody perhaps if you engage them in conversation, they keep that conversation going longer than perhaps what they would normally, or people we don't actually see going out and about, so that we're all aware of these people and who they are. And I think when we're doing studies, maybe not framing our study as a loneliness intervention or a loneliness study, I think that can be a real barrier, puts people off straight away, again, because of the stigma. And as I noted previously, we have subpopulations who are really vulnerable to loneliness. And I think one of the barriers to research is we don't do enough work with those subpopulations. We look at the general population and we design and develop interventions for the general population, but actually those interventions and things may not be as appropriate for some of those subgroups. So we definitely need a more personalised approach and a bit more focus on some of those individual groups. And as I said, a focus on prevention. Like I said previously, it's an issue, it's not going to go away. It affects people across the lifespan. Millions of people globally are affected by it. And we definitely need to do more work with people with lived experience to co-design with them instead of for them. And I think that's one of the biggest barriers, is that we don't work with these groups enough. So that's the end. I'm happy to open the floor to questions.